So the techniques that you would be using in the respiratory assessment would be inspection, palpation, percussion, and auscultation. We would start with inspecting the interior chest. You're looking for shape, symmetry. You're also looking to see if it's equal on both sides. You're looking at something called an AP diameter, which is anterior, posterior. And this should be a ratio of 1 to 2. So what does that mean? Let me switch colors. If I have a patient and I'm looking at their AP diameter and I'm looking at anterior's front, so this is going to be 2, and then I'm looking at posterior on the side, and that's going to be a 1. So posterior is the side view, anterior is the front view. My anterior is going to be bigger than my side view. Where would this change? This you would see a difference or would see a change in a patient who possibly has COPD. They tend to be barrel-chested because of the overinflation of their lungs over a long period of time. So they're equal. They are actually a 1-to-1 ratio in an AP diameter, or they'll call them barrel-chested. So that's why that would play an important part in order to assess. Some of the other things you're going to assess is the actual respiratory rate, the depth, the rhythm. You're going to look at inspiration and expiration. You should know that inspiration takes half as long as expiration. You're going to observe for any kind of abnormal breathing patterns. One of the patterns is called Kussmaul's. And this is actually something you would document. Kussmaul's means that there's rapid, deep breathing. You also have something called Cheyne-Stokes. Cheyne-Stokes is abnormal respirations characterized by alternating periods of apnea and deep breathing. I can tell you that you typically see Cheyne-Stokes breathing on patients who are palliative care or end of life. That is very common to see that type of breathing. Skin color, we're always looking for skin color. Are they cyanotic? We're looking around their lips. We're looking at their fingertips, their toenails. We're looking for their fingernails. We're actually looking to see if they are clubbing. And then when we start to inspect the posterior chest, we have them lean forward with their arms folded. And this actually causes the scapula to move away from the spine so we can get a better sense of listening to the actual lung sounds and inspecting. So one of the things you'll do, this is actually a picture from your textbook, is you're going to palpate. So what you're going to do is you're going to have the patient breathe normally. You're going to put your hands, the palm of your hands, on their back. You're going to put your thumbs together, and as they breathe in and out, you're going to see your thumbs move apart. What you are assessing for is equal on both sides of the movement of the thumbs and the hands and where they land. So you're looking for symmetry. The other thing that you can do is you're listening for a vibration. It's called fredemus. Fredemus is the vibration of the chest wall produces by vocalization. So if I place my palmar surface of my hands with my fingers hyperextended against the patient's chest, so just as you would be doing in this picture, you're going to ask the patient to repeat a phrase, and typically what they have them repeat is 99, 99, 99. And as they're repeating 99, you move your hand side to side at the same time, top to bottom of the chest. You're actually trying to assess if there's fluid in the lungs, if there's an absence of that echo or vibration when they say 99. You have to think, yes, we're in the world of where there are chest x-rays available to have this done, but I always try to remind students these are just extra steps and additional knowledge so that if you're in a location who don't have access right away to a chest x-ray machine, this is something that you can do. And what happens is if you hear an increase in the fredimus, the lungs are usually filled with fluid. If you do not hear it, it's typically a pneumothorax or possibly atelectasis. This is a picture from your textbook that's talking about the actual sequence of the exam of the chest, anterior, side, and posterior. And it's giving you the direction in which you would actually percuss and auscultate the lung sounds. Keep in mind the picture that you're looking at is a male, so you may have some variations on the anterior chest of a female where you would actually listen and be able to hear lung sounds. Make sure that you're placing your stethoscope over lung tissue, not bony prominences, and you need to listen for one full cycle, inspiration and expiration. I can tell you these are a lot of places to listen to. So this is ideal textbook world of how you would listen. If you have a patient in the clinical setting who has a history of respiratory problems or who came in with shortness of breath because they have CHF or heart failure, you're probably not going to be able to listen in all of these spots, or you're going to have to give them rest periods in between because they're going to end up hyperventilating. So you're going to do more damage. So just keep that kind of tucked away in your mind. When you go to listen to the lungs and you're auscultating them and you need to document, you want to think of lung sounds. You want to divide the anterior and posterior lungs into thirds. So you're going to document them as upper, middle, and lower. So if, for example, if I hear fluid or crackles sound like taking your hair and rubbing it together. And I hear that in the back, and I hear that on the right side, I'm going to document that as crackles posterior right lower lung field. So that means that I'm hearing it right about here. Okay? There are 3 normal breath sounds that you would anticipate hearing. You guys can review those on page 488. There actually gives you a picture, and then they talk about them in the paragraph. One of the things that you guys will be assessing are adventitious breath sounds or abnormal breath sounds. This includes a crackle, rhonchi, wheeze, and a pleural friction rub. And I will try to upload YouTube videos of those sounds because usually that's the best. I can't describe it to you. You actually have to hear it. For testing purposes, you're not going to listen to it on a recording. You're going to have to know a definition of it. But I do want you to hear it because that's what you're going to get used to listening for when you're out in the clinical setting. This is the picture from your textbook talking about percussion and what you would normally hear. What are the normal sounds that you would hear over percussion of the respiratory system? It talks about it in table 26-6, page 487. Just keep that tucked away. That's something you guys can review before boards. Sometimes NCLEX likes to ask questions about it. You don't really see a lot of doctors or nurses percussing. Every once in a while, if you go in for maybe a physical or have issues, the physician may percuss the liver, but you really just don't see it that often anymore. So I'm not going to spend a lot of time on that because we have so many other things that I want to make sure that you know and cover. So don't have to give percussion a lot of focus. Just know that it's there. and tuck it away, review it before you take your boards.